Thanks for coming out today, guys. I'm going to be starting with the elbow, and then I'm going to have Kurt cut in for the shoulder, and then we'll take questions at the end. Before we dive too far in, though, I do just want to go over why we're even qualified to do this, right? I'll go first. I studied at U of C here in town. I did biomedical sciences, but I quickly realized that I didn't want to do research the rest of my life pipetting in a wet lab. So I started looking elsewhere and came across chiropractics, and ended up going to the University of Western States in Portland, Oregon. I did that for a couple of years, got my bachelor's in human biology there, and graduated from the Doctor of Chiropractic program in 2020. And Dr. Kurt, do you want to tell us a bit about yourself?
Yeah, so kind of similarly to Evan, I was out in Kelowna for my undergraduate degree at the University of British Columbia Okanagan campus. Um, Took human kinetics there, so your offshoot of kinesiology, you could say. Um, yeah, just always was look different than Evan in the context that he realized he didn't want to do cell stuff and things like that. I kind of was always leaning towards this field to some degree. And yeah, chiropractic was the one for me. So ended up going down to University of Western States in Portland as well with Dr. Evan. We graduated in the same year, as you can see. So yeah, pretty interesting. Yeah, was down there for 3 years and we called her a day and came back up to Calgary.
Perfect.
Evan, you can take her away, man.
Right. Thank you very much. Okay, so let's just go over what we're going to talk about today. So the elbow, I like to break it up by the different layers of anatomy. So we'll go over bones, ligaments, add the muscles in, add the nerves in. I'm going to be talking about joint mobility and really how form meets function in a lot of these situations. I'm going to be talking about common injuries as well. So for each layer, bones and ligaments, etc. And then treatment options. Everybody wants to know what can we actually do about these issues. So we'll go through it. So taking it off, I like to start with this image. It just shows that what we're talking about is actually pretty complex, right? So the shoulder and the elbow joints, there's a lot going on there. And on the image on the left, you can see that it shows some of the vasculature in the arm, some of the lymphatic systems. There's more than we're totally than we can touch on, today. So if you do have questions about a system that we didn't talk about, please just ask us. We'd be happy to talk about it at the end. So I'm going to dive in and tell you about the elbow joint. And I promise you, I think it's more interesting than we give it credit for. So I'm going to try to argue that point here. But in general, the elbow is just the connection between your upper arm and your forearm, right? So the upper arm is bone is called your humerus. It connects into two forearm bones called your radius, which is the one on your thumb side, and your ulna, which is the one on the pinky side. But what I want to draw your attention to is the shape of these, right? So if we look at the radius right at the elbow, it's quite thin and narrow and rounded, whereas at the wrist, it's quite broad. And the ulna is the inverse. It's very thick at the elbow and thin at the wrist. And this provides the forearm the ability to do a twisting motion. So I have an image here. So you can see that it literally can twist, right? This is what gives us the ability to go from thumbs up to thumbs down. And it's pretty unique in the elbow. It's actually different than the most similar joint to the elbow would be the knee. And the knee cannot do this. You can't flip your foot from going down to up, right? So the I'm going to show you like the subtle differences between these and why this is possible in the elbow joint. So if we look at the front and side views here, we can see how the radius connects into the elbow, and I'm going to highlight it with a red box. That's the simple hinge joint, right? The back and forth that we always know about. But what's interesting is that the ulnar side is quite a bit larger, especially from the side view. You can see it's just completely like dwarfing the radius in terms of how much surface area is connecting. And that's because there's just a lot more forces that can go through this side of the bone. But what's interesting is because of this discrepancy, there's actually a third joint where the radius connects into the ulna, into this little groove, and it allows it to swivel, just like we saw in that last image. And that ability is pretty unique. And if we go back to the knee comparison, you can see that there's a lot of similarities here, but there's some subtle differences. So that blue joint is now the entire length of the knee. And the reason for this is you have a lot more forces that go through a knee than, say, an elbow. So it needs to be steady and secure and not slip at all, right? So the trade-off is that this is more secure, but it doesn't have the same mobility, right? In fact, that green joint is down here off to the side. So it's not weight bearing and it doesn't even move. Like in your shin, that is a solid static joint. That's not going to be moving. If it moves, we have a problem actually. So that's where this change of motion comes in place, right? And I can just demonstrate that again, right? This swivel action is really what makes your forearm unique. So that kind of covers the bones. If I move to the next layer, layer number two is if we add ligaments. And ligaments are these strong, fibrous connective tissues. And without them, the bones would just fall away from each other. This is like the paper mache that's like holding everything right where it needs to be. But it's not super rigid either. It needs to be flexible and give with our motions. So you can kind of think of it as like a really strong, thick, elastic band. And that joint we were just talking about, the radius, when it rotates, it's tucked underneath this ligament right here called the annular ligament. And this is where I'm going to get into some of the injuries that can occur. One of the more common ways to injure this particular area is actually when people swing their kids. It seems super innocent. You're just trying to have a good time, but when you pull up on the radial head, it can actually pull down pretty strong, and it can pop that bone right out from that annular ligament. And you'll know the kid's going to be screaming. It's going to be off to the side. It gets pulled down and then goes out off to the side, so it doesn't go right back in. This is one of those ones where you just got to go get it relocated at an urgent care, right? But there's more common injuries that can happen, especially in adults, to the ligamentous layer. So in this case, on the picture on the left with the pitcher, this would be something called pitcher's elbow, right? So if you recall, I said that ligaments are like these thick elastic bands. And if we're loading them up, right, when a pitcher winds back, they are not only bringing all the muscles into tension, but they're loading these ligaments and they're storing energy in them. And when they whip it forward, some of that energy gets released and they can really throw the ball fast. But you can imagine that these structures are being used constantly at their, the most that they can take. So after a while, they can start to wear, and you can get, small tears, which we call a sprain, or they can just have large tears and even rupture. So that's something we call pitcher's elbow. And then on the opposite side, on the wrist side of things, you can get something like a ganglion cyst. I put this one in today because I've actually seen them. I've probably had one or two a month for a while now. They seem to be happening more and more. It's almost always in the wrist. And if we look at an image here, you can see that those ligaments and the tendinous sheaths in between those bones, it can get irritated, say from a fall or a pinch in the wrist. And what happens is it starts to get inflamed and swell up, and it turns into like almost like a little mushroom stalk. And it'll start small and it'll just feel like an irritation, but the more it gets irritated, the larger it gets. And it can, this is a very large size one, but they can get this big. The good news is they typically they self-resolve. If it was this big, we would probably send for what we call an aspiration, where they stick a needle in, they drain it, maybe give a cortisone shot to get the inflammation down. Completely manageable, and something I do see fairly often, actually. Okay, so layer number three, this is the muscle layer. So if we go back to the different functions of your elbow, the major one that we think of is the hinge joint, right? And this is supplied by the muscles in the upper arm. So the classic bicep muscle that everybody thinks about when you're doing a bicep curl, that and the brachialis work to basically close the joint up. So to bring your palm towards your shoulder, that's going to be the flexor muscles. And then you have the opposite on the other side. You have the tricep muscles that are doing the extension. They're opening it up so that your arm is nice and long. So that's how the hinge joint is working. Luckily for the supination pronation, they were very nice with the naming. The supination is performed by the supinator muscle. The pronation is performed by two pronator muscles. They've kept it very straightforward. But again, if somebody were to come in and they're having issues with this sort of twisting motion, immediately my first thought is like, okay, I need to check these muscle groups and establish, are they functioning properly? And then the last group, there's tons more muscles in here, but I'm just going to classify them based on their overall function. So I'm actually going to have people do this one with me. So if you can stick your arm straight out away from you so that your fingers are pointing to the far wall, right? And your palm is facing the ceiling. If you were to bring your fingers down towards the floor and your palm is facing away, then you've just used all those extensor muscles on the outer edge of your elbow. If you then do the opposite and you bring your fingers up towards the ceiling so you can see your palm, you've now used all of those flexor muscles on the inside of your elbow. And you can even just grab, like if you do kind of a C shape and grab maybe like an inch in front of the elbow and just gently squeeze and go back and forth. You'll literally feel those muscles moving underneath your fingers. And that's what they're doing. They're flexing and extending your wrist. So something that we use all the time, every day, from sports to our jobs, right? And then if I were to get into, the common injuries here, well, a strain injury is really common, especially repetitive strains. So for our example, tennis elbow is the extensor muscles on the outer edge of your elbow on the thumb side, right? Those, if we overuse them, they can develop small tears in them, right? And that is irritating to the nerves, and it's going to send a pain signal. In general, like for pretty much all muscle injuries, it's going to feel tender and it's going to be diffuse. And what I mean by diffuse is it doesn't feel like a pinprick. Like it's more broad than that. It might feel like, well, this general area is sore. And people often describe that as like a tightness or a pulling sensation. And one of the ways we'll test that in clinic is, okay, if there's small tears in that muscle and I asked you to contract that muscle, it's going to irritate it. So we will check exactly which muscle is being irritated when we contract it to narrow down which one it is. Likewise, if I were to stretch that out, those fibers are getting pulled, and that also irritates it. So it's just ways to narrow things down. And causes we kind of touched on, right? It's repetitive strain injury. These are mechanical muscles. They can only take so much use before they start to wear out and fray and have injury to them. I mean, this one is called tennis elbow, but it could be through any sport. Racket sports are particularly tough on the wrist movements, right? But it could be pickleball, it could be badminton, it could be table tennis, any of those. But in fact, I probably see this most from trade workers. Construction workers get this a lot. They have to carry drywall or something repetitive day in, day out. It's just too much for the muscles. Electricians, I see a lot, carpenters. So definitely something that, if you have that repetitiveness of the task, it's just going to cause this issue. But this applies to all of those muscles that I talked about, right? It could be the bicep, could be the inner elbow, like this one. We call this golfer's elbow. Same cause, but now it's on the inside of the elbow with flexion movement rather than the outside with the extension movement. So just kind of an overview on that. Layer number 4, this is nerves, right? So the nerve layer is interesting, and they've done a great job naming these two. The ulnar nerve follows the ulnar bone, the radial follows the radial bone, and the median nerve sits right in the middle. And I guarantee you guys have probably heard of the median nerve, because anytime somebody has wrist pain, they always say, "Oh, you have carpal tunnel syndrome," which is a pretty good guess, honestly. That is definitely something that comes up a lot. There are other causes, but let's talk about what carpal tunnel syndrome is. It's named after the literal tunnel that forms along the carpal bones, which are just a fancy name for the wrist bones, right? And you can see in this cross section view that the walls and the base of that tunnel are formed by those bones. And the top layer is a tendon, or sorry, a ligament. And again, those they have a bit of give, but really not much, right? So there's a finite amount of space for all of these tendons and the median nerve to go through. So if there were an injury to that area or inflammation or swelling, there's just not enough space left. And that median nerve now gets squished up against the roof, and that's going to cause symptoms. You can kind of think of it as like if there's a garden hose and you pinch the garden hose in the middle and everything downstream of there is going to be affected. Same for this. If I pinch it off at the wrist, then the wrist, the palm, and even the fingertips are going to feel the effects of that. So it could be numbness, tingling, weakness. It might feel painful or like a burning sensation. Those are all signs of nerve irritation. So it would definitely point us in the direction of examining the median nerve more thoroughly. So that was the fourth layer. So let's just do a quick overview, right? So we covered the bone layer, the ligaments, the muscles, and the nerve, and a couple injuries for both, right? So we didn't really touch on fractures, but most people know if they have a fracture, to be honest. It's been a serious car accident, a big trauma. If they're not sure, if it was something like a hairline fracture, then that is something we can definitely address, right? Like if you're not entirely sure, we can send for x-rays, we can evaluate it and be sure. Ligaments, we talked a little bit about, right? Like you can have a dislocation. That was like when they swung the kid and it pops out. Sprain, or if it's really bad, a tear, that would be like the pitcher's elbow that we discussed. And then for muscles, talked about repetitive strain injury, but really any muscle can have that, right? Depends on what your task is, but those are like little microfiber tears. If it were to be sustained over a period of time, it might actually develop into larger tears, which take longer to heal, and we might need to add additional interventions on top of. And then nerve, right? We talked about that with the carpal tunnel syndrome, which is your median nerve. But I did want to throw this image up too because it shows that those nerves, even in the wrist, if we follow them back, they started in your neck, right? So, you might go to see a chiropractor and you have wrist pain, and we're asking, well, do you have neck pain or shoulder pain? And it might seem kind of out of the blue, but I promise there's some logic to it, right? We're checking the pathway of the nerve. Is it being affected in any of these other areas besides just the wrist? Because there are conditions that can do that. Okay, and then let's talk about some treatment as well. So for the bone layer, lots of things we can do. If it is just fractured, that's a different story, right? We refer out, get a cast, that sort of thing. But if the joint is just malaligned, then we can use things like adjustments or mobilizations. That's when we get in there and correct the joints. Or if the bone itself needs to heal, we can always use things like laser therapy. If you've ever had that, it looks like a little red light, might feel a little warm to the touch. It just provides deeper energy down to the cells that speeds up healing time in tissues that don't heal quite quickly. And bone and ligaments don't heal very quick. So for the ligament layer, same thing, right? If that joint is slightly out, and the capsule is preventing it from going where it needs to be, we're going to adjust that and get the mobilization that we need in there. Active release technique, definitely a little tender, but it'll do the job, right? We're getting in there to mobilize that tissue and free it up so that it can move in the correct manner. The inverse of that is if it was too lax, like if it's moving too much, what we want to do is stabilize it. So that might be something like K-tape or KT tape, rock tape, there's so many names for it, or even a brace, right? Just to stabilize the structure until it naturally gets some of the rigidity back. So this is just a picture. I'm sure you guys have seen athletes wear this. Seems to be really, really common now. And shockwave or laser, those are different treatments that we can apply to these. Shockwave is really good at helping with scar tissue. So that's something that we would consider if there is some fibrosis in there as well. For muscles, this is where active release technique really shines. In fact, everybody at Active Sports Therapy is trained in this. Every chiropractor, I should say, is trained in this technique. It's really useful at just mobilizing the fibers of the muscles. So our goal here is to basically pin it down, get a deep stretch into those, release any adhesions on there, and restore movement. We can also use something like this really long acronym, instrument assisted soft tissue massage. It looks like this. It's like a metal tool that come in all different shapes and sizes. And sometimes it's referred to as Graston, if you've heard of that. It's a tool designed to help scrape along the fibers to free them up as well. So it's a different approach, but same end goal. We can also use something called interferential current or IFC, which is like these little electrodes. We put those on, run that with some deep heat, and try to basically stimulate the muscle by contracting, releasing over and over to just get it to calm down. And then lastly, for nerves, nerves are a little different, a little special, right? So it depends on the cause of the nerve issue, right? So in carpal tunnel syndrome, it's that ligament or whatever is causing the swelling in there. That's what needs to be addressed. So if it's a muscle, we might use active release technique to calm that down, which would then affect the nerve. Or if it's a joint that's getting irritated and swollen and that's affecting it, then we will adjust that joint. If we need to target the nerve directly, we might do something like nerve flossing. This is like a home technique that we give people to basically mobilize it. We get them to stretch the nerve back and forth, and break up any adhesions that might be holding it in one place, or encouraging like entrapment syndrome. So it's just a technique to help mobilize the nerves, and it can be really quite effective. So that kind of summarizes the elbow briefly. I'm going to hand it off to Dr. Kurt now to do the shoulder.
Okay. Bear with us here one sec so we can just share my screen. Okay, perfect. Okay, perfect. Okay, so yeah, we can see this is the shoulder, or what when we see the shoulder, what we see it from the outside as. Lots of large tissues, right? So obviously from the front, being this side here, we've got our pec, we've got our deltoid. Evan's already touched on the biceps here. You can kind of see this little guy here on the side. That's our lat, or latissimus dorsi, big muscle. These little finger-looking things sit on the side of the ribs. They go to the underside of the shoulder blade. Lots of very large muscles impacting the shoulder here, just from the front. The backside, again, we see our trap on this side, upper trap, middle trap, lower. We get another bigger look at our lat down here, triceps on the back, deltoid again. Nice big horseshoe shaped muscle that wraps around the whole shoulder. In this little kind of opening here, that's our first kind of peek at our rotator cuff. Okay. Which we're going to spend the bulk of our talk about muscles on the rotator cuff, not on these big guys. These big guys, when something goes wrong, we know right away because it tends to result in a massive deformation to the tissues, which usually ends up being some sort of surgical fix, um, like pec tear being probably one of our more common ones outside of a biceps tear. Yeah, so those are the big ones in particular. This is the joints of the shoulder. We have technically three. The glenohumeral one is our first main one. That's this guy here. That's the shoulder joint itself. This one here is our acromioclavicular joint, or AC joint. And then we have the sternoclavicular SC joint. So that's where the clavicle itself is attaching to this sternum here. So this sternoclavicular, that's the first point of contact kind of between like the main body of the skeleton to the extremities. This is the next component of it. And then obviously, yeah, we have the shoulder blade and the glenohumeral joint here. Just again to touch on the movements, similar to what Dr. Evan had done here. Our first major one, we're looking at flexion, arms just going straight up in front of us like that. And don't think of it from like the elbow again, it's from up here. So this motion here, that's our flexion. Extension is in behind, as the photo shows here. Abduction and adduction. If we abduct, we take the limb away from the body. It's the same in the hip. The shoulder and the hip actually, from a structural component, are very similar as far as how they work. We only have two ball and socket joints in the body, and they're both at the hip and at they're both at one's at the hip and one's at the shoulder. So yeah, abduction takes it away, adducts it takes it back towards kind of what we would describe as bringing towards the body or towards the midline of the body. Our internal rotation here, you can see it, arms down by the side, palm comes across the belly. This one here, pretty much the opposite. Arm down by the side, hand goes away from the body. All that motion coming from up here, not just the elbow. Yeah. So bones for the shoulder. We kind of touched on these quick or earlier just a little bit. Evan obviously mentioned our humerus up here. This is our shoulder blade. It's our scapula. Okay. One of the kind of more odd joints or bones in the body, its only connection via like to the actual major skeleton is this. Sorry, I have a cat that just tried to jump beside me. Um, so yeah, that's we're looking at the clavicle there, attaching to the AC joint. Sorry, my son just got home from gymnastics. From the side, so we see the humerus here, obviously. When we look at this from the side, we almost completely lose the space where the humerus is sitting inside the scapula. It is pretty much like comparing a golf ball to a tee, like a golf tee. There is not a lot of surface area that the head of the humerus has to manage the inside portion or the glenohumeral joint. Um, so yeah, like that is it's the least stable joint in our body, effectively. And there's a lot of things that make it more stable, but they also come with problems too. From the backside, again, we can see like just the glenohumeral fossa there where the humerus sits into. Couple little points. This is our coracoid process and our acromion. Those will come in handy later for you guys. Here's our ligaments from the front. This whole big wide thing right around the humerus on the front portion over here, and then on the back portion. Oh, I went too far. And on the back portion here, that is our joint capsule. That is when we hear something like that you guys probably have, most of you have heard, frozen shoulder or adhesive capsulitis. That's just a fancy name for it. This is what we're talking about. This gets inflamed at the beginning stages and is super, super painful. And then it gets to a point because we haven't kind of moved the joint around, or we've just let it stay in one spot because of the pain, that then the tissues themselves actually start to adhere together. Now we lose that elastic component that Dr. Evan was talking about with the ligaments. That goes away. Our most common first things that we look for is to see, are we missing external rotation? So that's that one we kind of showed where it goes out like this. Okay. So yeah, that's a big portion of it. We can also see this little cut piece right there. That is the long head of our biceps tendon. That little guy runs up over here and back in underneath the coracoid. Okay, so pretty big, runs down through there. We can also have issues where this portion of that capsule over top of the biceps tendon can rip or become slack, which then will result in the biceps tendon slipping out of place. Sits in a little groove right there. The other big one, so this kind of section all through here, this is our coracoacromial ligament, and then our scapular clavicular ligaments. And this is just like the joint capsule essentially of the AC joint. These guys, if they tear, can result in what's called a separated shoulder. Okay. The separated shoulder is what we would call, Dr. Evan and I would call, an AC joint sprain. It's just different classifications will tell us what this looks like. So if you're someone who's had a shoulder injury before and you notice when you run your hand over top of your shoulder that that side has a little bump right on the edge and the other side's a little more smooth, you probably did at one point in time have an AC joint injury. Now, that doesn't mean it's still painful. Could be totally fine now, but that's a common thing that we'll see is that they'll have what's called a step defect. So you can see I'm right on mine right here. I don't know. Can you guys see that? And then if we roll over, we'll get that little bump. But sorry, we have a cat. So yeah, that's all of that. This is again, you can see the ligaments through there and everything else. Okay, so kind of touch on everything. Bone, fractures, not commonly going to see a humerus fracture. Is it possible? Yeah. But again, if you have a humerus fracture, you're probably not coming to see Dr. Evan and I. You're likely going straight to the hospital. Collarbone or clavicle, that's the most common fracture in the body. It's the most commonly fractured bone. Again, you're probably going to the hospital for that. It's also the second most painful fracture, according to some people. The joint dislocation, the glenohumeral joint itself is like I said, it's the most like lax joint. It has the least amount of structure. So, or instability, it's the most we lost that word there. The most unstable joint in the body. There we go. So yeah, just because of that, it's the most commonly dislocated joint in the body. Again, these types of things, especially the joint fracture, the dislocation, or sorry, the fractures or the dislocations, you've probably already had this managed. Now you're coming in to have like the after effects dealt with either Dr. Evan and I or one of our lovely physios at Westman or even at Willow Park. That's fine too. But yeah, so these are the big ones. So the dislocation, that's going to most commonly comes forward or down. Those are the big ones. If it's dislocating to the back, that's a whole other can of worms and is probably coming with fractures as well. The ligaments, so the sprains. So sprains to the ligaments, AC joint sprain, the capsular injury, like with adhesive capsulitis. Those are kind of our big ones. Oh, I forgot about that guy. That's our collarbone. Already touched on that, and that is our GH joint, glenohumeral joint. Okay. The nerve component for the shoulder. Lots of stuff. So again, we can see the neck over here. This big kind of thing, I'm sure keeps Dr. Evan up at night because it still keeps me up at night learning about it. This is our brachial plexus, this whole system through here. The nerves leaving the neck, they all come underneath our collarbone down into kind of the armpit area and then go from there down the arm. Because of this, they sit on one of our rotator cuff muscles or running in a neurovascular bundle within the premise of the subscapularis muscle. So in some situations, if we do have an issue within the subscapularis muscle, that can just, by the release of inflammatory markers, irritate these nerves. Okay. That can cause issues within the nerve. Again, Evan mentioned carpal tunnel. One of the things that I do that I find helpful and beneficial for my patients who do come in with carpal tunnel, I treat the nerve from shoulder to wrist. I just find it yields better results for the most part, at a quicker rate, which is, again, that's the big thing. How fast can we get you back doing the things you want to do or having this stuff not impact your life? Yeah. So that's kind of where it all runs through. And then obviously it goes down the arm. There's a few other nerve related issues within the shoulder complex, but for the sake of this chat, we'll kind of keep it a little more just on this stuff because the muscle components with the shoulder that we're about to get into, there's a lot of things that can go wrong. So yeah, that's just a picture of the shoulder and all the nerves, and you can kind of see from the neck down how they all play in all the way down to the hand. Okay, now we're getting into the rotator cuff muscles. So we can see from the front here on the left and the back side of the shoulder on the right side here. So supraspinatus, little muscle, we can actually see it from the front and the back. It is on this side, right up over here, goes to there. And on the back, it's right here. You can see my little arrow. Infraspinatus, it's right underneath it, right under this spine. So that helps us with the name. Supraspinatus, infraspinatus, above spinatus, below spinatus. Teres minor, which also has a older sibling or bigger sibling named teres major, is right here. And then teres major is actually right here. Not technically considered one of our rotator cuff muscles, so we kind of leave it out. But again, the biceps isn't also one, but it's pretty much an accessory rotator cuff muscle. Subscapularis, this guy sits on the front side of our shoulder blade. So its closest place of articulation to the body is the rib cage. It's right there. It runs right across it and then shoots up across and over into this front portion of the humerus. Biceps, kind of mentioned. This big guy right here, we have two components to our biceps. We have the long head, which we already kind of talked about over here, and we have the short head, which runs to the coracoid, which is over there. That's why this guy is important. So again, biceps, two heads. That's where that comes from. As far as the tricep goes, which again, one of our kind of other shoulder muscles, three, there's three heads of the tricep. Okay, so again, they just impact the shoulder in different ways. Rotator cuff tears, the big one. So yeah, you can see here, study of almost 1,400 shoulders, found nearly 21% had a full rotator cuff tear. They're the most common shoulder injury among patients with shoulder problems. And then the other interesting part here, approximately 35% of tears are symptomatic. So that means 65% of those people who have rotator cuff tears don't know they do. So just because we have one doesn't always mean that it's the cause of our pain. It's something to keep in mind. Now, with that being said, the supraspinatus muscle is the most commonly torn of our four rotator cuff muscles. So again, we can see it up here. Okay. Prevalence of rotator cuff tears. Yeah, so we can kind of see with this one. So risk factors, there's obviously a lot. Occupation, what we do, how often we're using our shoulders, the overuse component, micro traumas, metabolic disorders such as diabetes, hypertension, cigarette smoking, genetic predisposition. Do we have issues with soft tissues that come from our genetic aspect? One of the other ones that has kind of come to light recently, which I should have added, is actually menopause, perimenopause, and menopausal situations, and post, obviously, as well. They're finding that with the decrease in estrogen, it's changing how our soft tissue, so particularly tendons, respond to load. Which is also kind of why one of the age ranges and demographics we see the most adhesive capsulitis, so frozen shoulder, or rotator cuff tears is in that kind of like 45 to kind of 65 age range, roughly. So yeah, which that again, that kind of falls in with our postmenopausal kind of demographic of women who are suddenly never having issues with their shoulder, haven't really had any trauma or overuse, nothing's changed in their life, and then suddenly this is becoming a problem because with those hormone changes, things were being managed prior by having the hormone, like the proper hormone dosage within the body that our body naturally has, and then after menopause, losing all that estrogen, they end up developing these issues. There has been some interesting research on it. Dr. Lovely at at Willow Park is actually kind of the go-to for that type of stuff. So any of our menopausal patients with shoulders, she's definitely a resource that I have utilized multiple times for information on this stuff. Biceps tendonitis, another kind of common one here. Two attachment points to the shoulder, like I said, long and short head. Tendonitis itself is just an acute inflammation of a tendon, most commonly related to overuse. And yeah, most commonly impacts the long head of the biceps, so up in through that shoulder. If we have an issue with like a tendon rupture related to the bicep, it's almost always the short head, which is over here, which we're not really touching on that one. Again, you know pretty quick when that happens. That portion of the bicep will retract, and then you have kind of a weird looking sign within the bicep that's called the Popeye sign. Impingement. This is another pretty common one. So yeah, caused by inflammation of the subacromial bursa for the most part. So the subacromial bursa lies right under here. So if we were to remember back to where those muscles ran, we can see supraspinatus running down here. When that shoulder comes up, it'll push up on that bursa. So if we have a thickened tendon or an inflamed muscle within here, so from like a tendonitis or a tendinopathy to the supraspinatus muscle, that can cause that bursa to, by its own, become inflamed. Then, just the way the shoulder itself works, when we bring that arm up, this is our kind of shoulder, right? The way it comes up is as we bring our arm up, the bone obviously comes up, but then it should slide down. So the muscles, the subscap muscle, when functioning properly, will bring that head of the humerus down. And then that helps us to limit that subacromial burst of impingement. Um, this whole situation is most commonly found with abductions. So that movement out to the side, this guy. So between 60 and 120 degrees, that's when it tends to be at its most painful. Below that, we just don't have the contraction space. It's not pushing on the bursa. Above 120 is when that head of that humerus does tend to dip, even with a subscapularis muscle that maybe isn't functioning properly, just based off the anatomy of the shoulder. Yeah. So that kind of covers the quick and dirty of it. So again, bone fracture dislocation was common. Ligament component, sprains and tears of those ligaments. The nerve, we're looking at nerve compressions or nerve irritations for the most part. Muscles, we have a repetitive strains, tears, tendinitises. Some of you who have shoulder injuries, if you do, or who have heard of it, tendinitis, tendinopathy, tendinosis, there's a lot of names that kind of all start with tendon. Tendinitis essentially just refers to the acute stage. It's when it first starts for the most part. It's when it's really inflamed. It's the inflammatory stage of that. Tendinopathy just kind of tells us that it's reached a point where the tendon itself has thickened a little bit. And tendinosis is the broad term for all of that for the most part. But yeah, that's just a little background on what that stuff means when you hear it from a practitioner. Treatments. So as far as the treatments go, not drastically different for the most part than compared to what Dr. Evan had discussed with the elbow. Bone and joint adjustments, mobilizations if we need it, laser, things like that. When we're trying to manage bone and joint, we are looking predominantly at like fractures or some sort of impingement type situation. So that's where the impingement component, that's where the adjustments and mobilizations would be beneficial. We can adjust shoulders, that is a thing. But it's not just backs. So yeah, easy mobilizations like that. And then laser, obviously, if we do have a fracture, just to help make sure things are healing. We're trying to do our best to make sure they heal as fast as we can. Ligaments, again, adjust if we can, just to kind of bring that movement through that space if it is a little too sticky or not moving as well, as much as we would like. Active release and laser, again, as Dr. Evan had mentioned earlier, pretty handy. But in the situation of like, say, an AC joint sprain, where we likely do have some laxity within there, yes, we might do some active release to them on the muscles in around the area to better allow them to move and support the tissues that are damaged. But again, we're not probably going to get into that muscle or that ligamentous tissue until it's reached a good point of healing. Rather load the tissue if we can, or get that laser going. Nerve, again, active release, super handy in getting the muscle to relax or getting the muscle away from the nerve. Laser to decrease that inflammation, help things again get them healing. And then exercises, home care is huge for nerves. Nerve glides and nerve flosses, as Evan had mentioned. Active release, again, that's its bread and butter. That is its bread and butter, is the muscle component. Again, same with instrument assisted soft tissue mobilizations, manipulation, massage, whatever you want to say that M stands for. And then laser and exercises. Exercises, honestly, for the shoulder, when it comes to rotator cuff, things like that, whoops, see, wrong button. That is our big one. The active release, the IASTM, the laser, all of those are going to be passive care stuff that help bring pain down. Long term, it's the exercises. It's what we get you guys to do at home, how diligent you are with your programming. That's going to be the big take home as far as, does this go away? Or we can get it going away for a couple of years, maybe a year or two, but does it stay away? Does our shoulder function? Because if our shoulder doesn't function properly, we're likely to have this stuff come back, which is just kind of the nature of the beast because we use our arms so much. Alrighty, that's the shoulder. I'm going to kind of bring Dr. Evan back into this and we'll
That
go
was
from
great.
there.
Thank you.
Trying to see. There we go. Did we have any questions? Thanks for coming, everybody.
We'll share mine just to leave it up on the questions page. Can you guys see that okay? One of the things I did want to mention is there's definitely overlap, right? Like bicep is going to be doing, it does double duty, right? Because it crosses the elbow joint, but it also crosses the shoulder joint. And I think often what happens is people think, well, bicep curls, that's what the bicep does, but it's way more than that, right? Like it's going, there's two heads, right? Like one's going right into that shoulder capsule, and the other one's, the shorter head's going out to that acromion. Those are super important in acting on the shoulder. And I think there's almost a disservice that gets done when we talk about the rotator cuff of like the rotator cuff is technically like four muscles, but there's so many more in there that need to be checked and evaluated. So I like that you went through all of those. I thought that was really useful.
Hi guys.
I think
Go ahead.
sorry, Renee, go ahead.
I do notice that Chris has a question. Chris, you can go ahead and unmute and ask it.
Yeah, if you want to.
Okay, so whether frozen shoulder or just rotator cuff injury, um, especially I guess with this frozen shoulder that's been dormant for some time, is there not some maybe use of muscle activation therapy or something like that as well that might be useful?
Yeah. Do you want me to take this or do you want to do it?
Yeah, you can take it if you want.
Okay.
We can bounce off each other as well.
Yeah, just add in at the end. I think you're 100% right. So frozen shoulder, right? There's that freezing stage, and I'm a little curious. What did you mean by dormant? Can you elaborate on that when you said dormant frozen shoulder?
Well, I guess as was said, is if you don't use it, it becomes frozen, right? Which I would
Yeah.
assume. And I've had a frozen shoulder myself, and I know I let it sit for a long time when I had a rotator cuff problem, and it became frozen. So I guess I'm looking at that as is just lack of use.
Mm, mhm.
Mhm.
Definitely. So when we isolated this into like, ligament and then muscles, but we can't really think of it in that way. And I think that's what your question speaks to,
Yeah.
is that the muscles and muscle activation is important for that joint movement, right? And if we can get that joint moving more, that means the capsule has to stretch. So if we're giving you exercises in home care, like pendulum swings or whatever it might be, we're trying to get you to not only move the capsule, but we will also be having you activate the nearby muscles because it's essential that they are working together. When we presented, we kind of isolated them, but it is essential that they're both being used to help with the treatment.
Mhm. Yeah.
Do you have
Yeah,
anything?
Evan, Dr. Evan pretty much nailed that. Like, um, in that kind of that acute inflammatory or stage of frozen shoulder, it's so uncomfortable that we end up not moving it, right? So the portion of like muscle activation techniques where like we are using MAT to push against it, to engage that muscles. When we have a patient who has frozen shoulder, some of the first things we're doing is trying to keep those muscles active, whether or not it's through isometrics. That is the basis of our first thing, which is muscle activation technique for the most part, is pushing into something, taking it through a shorter range, just to have those muscles continue to fire in that stage, because that can help to sensitize the muscle to make it so it's less painful, which is one of the very odd things when it comes to muscles and tendons. If we gently load in an appropriate manner, even while it's painful, it actually can sensitize and take that pain away. It's sounds counterintuitive, but believe me, it is how it works.
Yeah.
And
Yeah.
I think we have another question as well.
Thank you.
Yeah.
You're welcome.
Hi,
What's the other
sorry.
one?
We do have a question in the chat. Is that the one you were referring to?
Oh yeah, I see
Yeah,
it.
the dry needling one there. So I'll start with the dry needling component. Dry needling is super, super helpful. It's an awesome tool. I personally don't dry needle. Just not something that I've gotten around to taking a course to do yet. But yeah, it's something that I think is super handy. As far as when to use it, it's so we kind of touched on like instrument assisted soft tissue mobilizations or manipulations, and then active release. Active release itself is just another soft tissue technique. They all are similar, even including dry needling, but they differ in certain aspects. So how active release, how that one works, we're obviously stretching the tissue out. We're trying to get it to release and thus bringing back a more normal length to the tissue, because it's not uncommon that the tissues will kind of get adhesed together and then they don't contract properly and they don't lengthen again properly. So if we're looking at something like dry needling or instrument assisted thought or instrument based soft tissue work, instruments kind of similar. It helps to relax or break down scar tissue, get the resting tone of the muscle better, not changing the length. Dry needling is very similar in that concept. Now, mind you, dry needling probably infinitely more comfortable than instrument assisted soft tissue. And it is infinitely shorter as far as the treatment time frame. The needle goes in, gets wiggled around a little bit, and it comes out. The tissue relaxes right away, and it essentially feels better pain wise, probably within 24 to 48 hours. It's feeling better again. Now, dry needling goes really well hand in hand with exercises again, because it takes that pain away a little bit, helps to sensitize the tissue, and then we can get into our exercises. So again, utilizing that versus active release or something of the sort is just dependent on what your preference is or things like that. Hope that answered your question.
Yeah, and I'm just going to touch on it too. I personally, I think dry needling is great. I don't perform it myself. There's lots of clinicians within AST that do it, so it's definitely something our clinic offers. I'd say for the most part, when you use it, is muscle and tendon issues, right? Like you're not going to be using it on bones. Ligaments are getting way too deep. So that's usually when it's used for. Dr. Kurt and I are probably going to do something like ART or the instrument assisted, but everybody responds differently. Like if our modalities aren't working, then we'll prefer for dry needling with one of the physios at our clinic. So it's definitely, in the bone and tendon region. I see a couple more questions, so I'll start with the next one. It says, what causes popping in the shoulder, raising and lowering of the arm? Can be a couple things. So the way I usually describe this is popping. There's two reasons for it. If you've ever cracked a knuckle before, it popped, right? But you can't pop it again, right? If it takes 20 minutes or so for it to reset. In that case, that was the joint itself that you just heard pop. It's a little air bubble in the fluid of the joint. It formed into a bubble and it collapsed, and you hear the pop. If you can do it every time you lift your shoulder up and down, it can't be that. So it's not from the joint. It's from the tendon. And what happens Dr. Kurt mentioned this, is that tendon, typically it's your bicep tendon, fits in a little groove. And sometimes what holds that down, the roof of that groove, gets ripped. And when it slides over it, it's like a taut elastic band. So you can imagine as you start to lift your shoulder, it's tight, 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 click. It popped over the bony edge and it just made the sound. But then you lower it down and it just slowly slides back into the groove. But then you lift it up again and it's tight, 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 and it pops. So if it's every single time you're doing it, it's probably a tendon snapping over a bony bump. If it's once every 20 minutes or so, it's probably the internal joint creating one of those bubbles. I hope that helps.
To build off that one as well, we also have something called crepitus, which is just like capsular noises. So the capsule itself, that we mentioned, it's just a big, massive circle of ligament that if that does have some sort of adhesions or issues within itself, if maybe we had a capsular issue at one point in time, that can sometimes just make noise. And that can sometimes be those like, I don't want to try to imitate it, but it's almost like scratching Velcro. Yeah, like it's like I'm not going to try, but it's like a yucky noise.
Yeah, it's like a door on a band hinge. I don't know. It kind of creaks.
Yeah.
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 Okay, so next one is, what is happening to my shoulder when I sleep on my side? Why is side sleeping bad for my shoulder? This one might be pretty specific. There's lots of different things. One of the big things is when we sleep on our side, that compressive load, right? It's a ball and socket joint. You're kind of pushing in. That can be direct compression from surface to surface. And if there's any degeneration in there, if there's some arthritis, if there's even a muscle that's already injured or inflamed, you're just exacerbating that for up to like 8 hours a night by continuously pressing on it. So that there's a lot of possible answers to that one. I would say if sleeping on your back feels better, then it probably is something to do with like the compressiveness of that. And it's worth investigating. Like, why is that happening? Is it a muscle? Is it a tendon? Is it the joint? Worth looking into. Kurt, what are your thoughts?
Yeah, pretty similar to that. The easiest way to sorry, excuse me, kind of think about that one is, as Evan said, like you're in that position for the most part, usually for, depending how well you sleep, probably at least a couple hours before we roll off of it. So if we are like flat on our shoulder, that's again that compressive force down. If we're kind of rolling more so off the back of it, now that shoulder is being pushed forward, right? So now we're stretching all that tissue and it's sitting in that position for again 2-3 hours. If you're someone who can sleep in the same position for 8 hours, even 8 hours, right? So again, it's just positional as far as that being in one position too long. Could just be playing a role, but yeah, as Evan said, it could be a situation of like you have an issue with the shoulder already, or and that's just kind of aggravated it. Like, yeah, there's a few too many confounding factors to say for sure. But yeah, usually that's the big one. It's just the time spent in that position is the big portion.
I will say in general, sleeping on your side is not bad for you. Just so you know. Like,
no.
Side sleeping is okay.
Mm-hmm. I would agree. It is back and side are kind of the big positions that I would say are favorable. Another question here. What to do when your scapula has dropped and turned?
So that might be like winged scapula.
Yeah. Yes.
Yeah.
Not 100% sure what you mean.
Okay. I mean, I'll try to take this. So
there's a few.
I'm not entirely sure either, but what some conditions cause the shoulder blade to start to drop down. Kurt touched on a few things that can cause that, right? There's ligaments that hold it into the correct location. So if there's been a prior trauma to those, sometimes they rip and the scapula can sit and sink lower down. If it's turning out, we typically call that a winged scapula, and it looks like it's coming off of the rib cage a bit. It'll sit higher than the other side. Typically, it's just one side, right? And what happens is you kind of see that gap of it pulling away, and the skin is pulled taut over top. What would you do about that? First, you probably want to get it assessed to make sure, like, if it's a recent trauma, definitely. If it's been something you've had for a long time, then it's okay. Well, we need to strengthen the certain muscle groups that pull that shoulder blade back up against the rib cage. So we're talking things like the rhomboids, by pinching the shoulder blades back, things like rows would help strengthen and secure that. One of the other things Kurt mentioned was like the only bony connection from your shoulder and your shoulder blade is your collarbone, and that's on the front. So if it's coming and rotating off of the back, all of that is held together by muscle attachments. So those muscles are the ones that need to get strengthened and help secure the joint up against the rib cage and towards the spine.
Yeah. So just again to kind of build off that one, I'm thinking like so if we picture like I wish I had something that was triangular, but like if my hand's my shoulder blade or like the scapula itself has a lot of like articular movement. So like the way it moves across the ribs. So if it's a situation of like this being the top, the outside, along like the middle border, and then like down the bottom, if it's going like moving down like this and then shifting like that, that can sometimes be nerve related. We can also like if it's lifting like Adam said, or not Adam, sorry, Dr. Evan said, um, that's that winging of the scapula. Um, if it's dropped like this and gone up and turned, again, there's a lot of different components to why. Like as Dr. Evan said, if that is a like recent onset, I think making sure that it isn't a nerve related issue where like we have like some sort of like palsy within a nerve, which is it's like the long thoracic nerve is the nerve that supplies all of those muscles in the back side of the shoulder blade. Um, Dorsal scapular, long thoracic dorsal scap, one of those two. Sorry, that nerve always tripped me up. But yeah, one of the ones that comes from the brachial plexus that still keeps me up at night. Um, so yeah, if that nerve does have a bit of a palsy or some sort of issue with it, or an impingement that it's causing it to lose muscle function, then that's definitely something that needs to be evaluated. But if it's not, and it's just kind of you've noticed like it's been going on for a long time, it could be again. We focused on the glenohumeral joint for the most part as far as the shoulder went. There's a lot of conditions that relate to the shoulder blade, which just for today's sake, we just didn't have the time for that. Which I should have maybe mentioned a couple things with it, but wanted to be able to answer some questions too. But yeah, definitely strengthening usually is a big play. It's usually the biggest one. Would be the most helpful in those situations. But again, knowing what to strengthen is the important part of it, as far as what would be relevant to combating that issue to get the shoulder blade back to where it should be. I hope that makes sense and answers your question. How are we doing?
I think that's everything.
I think it is. Thank you so much for your presentation, guys. This was fantastic, very informative. With those complex situations, I can't help but wonder if a visit to the clinic and an assessment would be the best protocol to see what, the individual is kind of
Yeah.
experiencing. Then you can kind of get in line, get a treatment plan moving that way. Both Dr. Evan and Dr. Kurt work at Westman Village full time. They're easy to find. Everything that you need to know is on the website. and the link is in front of us. What we will do is if you have any more questions, or if you want to review what you've seen tonight, you'll be receiving the playback link within the next 24 hours with a thank you. Thank you both Dr. Evan and Dr. Kurt for your time. Thank you to everyone that was live today. We had a hearty group and we appreciate your time. If you have any ideas of different presentations that you might be interested in, we're always open to that. So please reply back to the email and let us know. And I'm sure that Dr. Evan, Dr. Kurt, and many of the other practitioners would love to create more informative webinars like this. I think that's all. Do you guys have any more thoughts?
Just
Yeah, I would just follow that up with, yeah, like if you guys do have like things that you want to know or things that are of interest to like active sports therapy patients, like, yeah, please let us know. Because one of the hardest things about doing these webinars is like, what do you guys want to know? Because like we have too much knowledge on a lot of these topics. So trying to get it to what you guys care about and what is relevant to you is sometimes the hardest part. So again, feedback, things you like, things you didn't like. We've got thick skin. Please be nice though. But yeah, definitely things that you guys want to know about, things that are of interest. It's always helpful to help us make the next one better, or just making sure you guys get the info that you want.
I completely agree. And thank you very much for coming.
Yeah, thank you,
Yeah, thank you.
everybody. Thank you. We'll talk soon. Bye for now.